Hello, I'm Dr. Cassandra Moore. I am a practicing medical oncologist in the genitourinary division of hematology and oncology. My area of specialty is prostate cancer. So I'm here to talk to you today about androgen deprivation therapy. Androgen deprivation therapy, also known as ADT, is a very common strategy that we use in the treatment of prostate cancer. It's also sometimes known as hormone therapy. And basically, we use this approach to manipulate the hormone levels in men with prostate cancer in order to control their disease. So there are different types of androgen deprivation therapy. And basically, the whole purpose is to control the level of androgens, which are also known as male hormones, in the body, and in that way control prostate cancer by either limiting their growth and keeping from them what they need to grow and thrive. So there are different ways to achieve this. There's obviously orchiectomy, which is the removal of the testicles and therefore removal of the glands that produce testosterone. However, this is something that is irreversible, and oftentimes patients like to have treatment that can have the same effect, but without that either permanent change or the surgery involved. So another way of blocking hormone production is through the use of medications called LHRH agonists or also LHRH antagonists. These are both medications that can be injected or deposited a small implant under the skin, and they basically act on an area in the brain to inhibit your body's natural production of testosterone. The agonists do it by making the body feel that there's plenty of stimulation, and over time it will decrease the production of testosterone. And the antagonists do it by blocking the receptors in the brain so that they don't release the hormones that cause the production of testosterone. Other hormone therapies are called anti-androgens, like Casodex. These are typically used in a brief course at the beginning of a treatment with an LHRH agonist to prevent a flare of testosterone that might cause increased symptoms. Androgen deprivation therapy is usually tolerated pretty well, although there are side effects to be aware of that are usually the result of the lowering of testosterone. One of the most common side effects is hot flashes. In this way, people often report the lowering of testosterone as a male menopause. Usually this can be relieved with dressing in layers and avoiding alcohol, avoiding caffeine, and some of the triggers of the hot flashes. If the hot flashes become too much of an issue, a patient can talk to their doctor about other medications that may help relieve them. However, they often tend to lessen over time, and usually for most people, they're not too much of a problem. One of the effects in lowering testosterone with androgen deprivation therapy can be a decrease in bone density. Your doctor will likely order a baseline bone density test and will continue to monitor while you are on treatment. Some of the things that can be initiated to offset bone loss is exercise, use of calcium and vitamin D, and in some cases when there is bone thinning or bone loss, your doctor may recommend a bone-directed therapy. Some men are concerned with the sexual side effects with the lowering of testosterone. Sometimes having a lower testosterone can lead to a decrease in libido or interest in sex or an inability to perform. If a man has these issues, they can speak with their urologist about ways to combat or strategies and approaches to address this. Androgen deprivation therapy can be used in a number of ways in the treatment of prostate cancer. Sometimes we use it up front with the initial diagnosis in combination with radiation therapy to help the radiation therapy work better in controlling and potentially curing the disease. Although hormone therapy alone is not a cure for prostate cancer, it can control the disease for many years Sometimes we will use it in an intermittent fashion in order to offset the side effects experienced, where we will treat someone with it for a period of time and then take them off, and then if the PSA rises again, treat them again. And sometimes we use it in a continuous fashion, like if disease has spread outside of the prostate to other areas and is what we would consider metastatic disease. In terms of androgen deprivation therapy, there are different approaches to treatment. When a patient is started on androgen deprivation therapy, depending upon the extent of disease, they may be treated in either an intermittent or continuous fashion. So the intermittent approach may be an attractive approach for patients who don't have disease that has spread throughout the body, but have a rising PSA. In that case, we will usually treat initially for approximately a year and then stop the androgen deprivation therapy and monitor the PSA closely. At the point that it starts to rise and reaches a threshold, we typically use a threshold of 3, androgen deprivation therapy will be reinitiated until the PSA becomes undetectable again. In this way, the hope is to limit some of the side effects that we spoke of and still be able to control the disease. While at this time, the use of androgen deprivation therapy as a neoadjuvant approach prior to surgery does not have a role, we do use it prior to radiation therapy and concurrently or at the same time during radiation therapy to help the efficacy of the treatment. Depending on the risk of the prostate cancer, based on Gleason score or PSA or doubling time, the duration of treatment may be anywhere from 6 months to 2 years. Androgen deprivation therapy can be an effective therapy for many years. However, there is sometimes a period where it no longer becomes effective. There may be a small population of prostate cancer cells that figures a way around testosterone and the androgen receptor to be able to grow. If the PSA starts to rise and becomes detectable, we will continue to monitor this over time. Typically, 2 subsequent increases in PSA confirms what we call castrate resistance. Treatment with androgen deprivation therapy is typically the initial approach to the treatment of prostate cancer that has spread outside of the prostate gland. However, it does not interfere with future treatments such as chemotherapy or other salvage treatments if the patient did not previously receive radiation. We also often continue androgen deprivation therapy even when the PSA has started to rise, and we add on additional agents like secondary androgen receptor blockers or chemotherapy. Thank you for taking the time to watch this video and explore this topic with me. Again, I am Dr. Cassandra Moore, Mayo Medical Oncology, Arizona. I encourage you, if you have additional questions, to continue to explore the website using the tools available and to follow up with additional questions with your doctor.